Hey everyone, let's jump right in. Welcome back to part 3 of our explainer series on vestibular rehabilitation therapy. Today we're unpacking the precise evidence-based rules for VRT prescription. We're talking about the exact difference between a program that actually works and a simple checklist that's just destined to fail by week 6. We're going to move way past the basics here and really drill down into prescription frequency, exercise duration, progression rules, and that absolutely vital symptom provocation window. Let's kick things off with a clinical paradox I'm sure we've all run into. Imagine two patients, right? Patient A and patient B. Both have similar deficits, and you give them the exact same exercise list on the exact same day. But fast forward to week 6. Patient A is back out there running, feeling awesome, while patient B hasn't improved at all. It's incredibly frustrating. So what gives? Well, the secret is that while the exercise list itself was identical, the dose, the progression rules, and the neuroplasticity rationale you gave them at session 1 were totally different. So, to map out a clear roadmap to fix this, today we'll be covering the prescription paradox, dosing by mechanism, the provocation window, engineering patient adherence, and finally, synthesis and handoff. Section 1, the prescription paradox. Let's get right into why those identical exercise lists are failing us. Here's the absolute cornerstone of effective VRT. Generic vestibular exercises just do not drive plasticity, period. Only doses that perfectly match the neurological deficit and provoke the exact right level of symptom will actually force the brain to adapt. So the real secret separating a win from a week 6 failure isn't some magic new exercise. It's the specific dose, the tailored progression rules, and that crucial neuroplasticity rationale you'll deliver to your patient right on day 1. Moving on to Section 2, dosing by mechanism. This is where the science hits the clinic floor. Selecting the dominant mechanism is honestly the single most important decision you're going to make in your prescription. You have to ask yourself, what's the primary deficit here? Are we targeting adaptation of the vestibulo-ocular reflex? Are we aiming for sensory substitution because vestibular input just can't be restored? Is it about static and dynamic compensation? Or are we relying on habituation to dial down central responsiveness? Once you nail down that mechanism, your exercise category basically chooses itself. Let's take adaptation as an example. Picture the classic VORX1 setup. Your patient's eyes are locked on a steady target while they turn their head at, say, 1 to 2 hertz. Now compare that with VORX2, where the target and the head are moving in opposite directions. That literally doubles the neurological demand. Both of these rely on an error signal, retinal slip, to drive cerebellar learning in the flocculus. But here's the kicker. If that target is perfectly clear and super easy to see, the exercise is too easy. You absolutely need that slight blur to trigger adaptation. And the great news is, we've got precise trial-backs numbers for all of this. For gaze stabilization, like your VOR, X1 and X2, you're looking at 3 to 5 times a day, for 1 to 2 minutes per direction, progressing based on clarity and speed. For habituation regarding motion sensitivity, you want 2 to 3 times daily until their symptoms drop by about 50%. If you're using Brandt-Daroff for residual BPPV, prescribe that 3 times daily, 5 reps each side, until the residual symptoms are totally gone. Meanwhile, static balance and dynamic gait are dosed daily, anywhere from 5 to 15 minutes. Okay, let's look at how static balance actually builds, because progression is just as vital as the starting dose. You always start with a nice, wide, stable base. When that gets too easy, you systematically take that stability away. First, reduce the base of support, from feet apart to feet together, down to a tandem stance. Then, take away their visual cues by having them close their eyes. Finally, you mess with the somatosensory input by throwing in a compliant surface like a foam pad. It forces the brain to rely heavily on those vestibular inputs. Dynamic gait is pretty similar. It's all about layering complexity. We start with basic, uncomplicated walking. Then we layer in head turns, looking left, right, up, down, all while keeping a straight path. Once they've got that, we really up the ante with a dual-task cognitive load. Think having them count backwards by 3s while walking. Finally, you throw them onto uneven terrain or into busy visual environments. The goal is always to confidently push their system just a bit past what it can currently handle. Which perfectly segues into Section 3, the provocation window. We know the dose, but how hard should we really be pushing? Listen, if you take nothing else away today, remember the symptom rule. No symptoms means no signal. Literally, if your patient is cruising through their exercises feeling perfectly fine, their central nervous system is not getting the error signal it needs to adapt. A lack of provocation is actually the #1 reason rehab programs hit a massive wall by week 4. You just have to push the dose. Think of it like a provocation curve. You want your patient firmly planted in the green zone. That means targeting mild to moderate symptoms, maybe a 3 or 4 out of 10 on a dizziness scale, that completely settle down within a few minutes of stopping the drill. But if they cross into the red zone, experiencing severe symptoms that drag on past 30 minutes, the dose is too high. But here is the absolute golden clinical rule. You tell them to back off the intensity, you never, ever tell them to stop completely. Tying all this together takes a structured timeline. Once you've identified the deficit and applied your frequency rules, you've got to retest at that 4 to 6 week mark. Use your objective measures to make a call. Do we advance the complexity? Do we hold the current dose? Or do we switch the mechanism entirely if they've plateaued? All right, moving to section 4, engineering patient adherence. Because let's be real, even a flawlessly dosed, physiologically brilliant program is completely useless if the patient doesn't actually do it. And the numbers here are crazy. If you open every single program with just a quick 1-minute rationale explaining the neuroplasticity behind what they're doing, you roughly triple your 6-week home program adherence rates. Triple! When they understand that feeling dizzy during the drill is actually their brain healing rather than a sign of damage, their fear vanishes and compliance skyrockets. And you know what else? You can double that compliance again compared to just giving verbal instructions. How? By providing a written and video home program combined with a symptom diary. The videos ensure they're actually doing it right, and the diary keeps them accountable while giving you hard data on their provocation zones. So here is your 5-step adherence playbook. 1. Deliver that 1-minute neuroplasticity rationale. 2. Give them written and video resources. 3. Use a symptom diary. 4, and this is huge, engineer one functional win at session 1. Find a small, provocative movement they hate, modify it so they can do it slightly better, and show them immediate progress. And 5, schedule a week 2 telehealth review. That quick check-in catches drifting patients right when they're most likely to throw in the towel. Finally, section 5, synthesis and handoff. Let's distill this whole explainer down to the core takeaways you can literally use in the clinic tomorrow. Always match the exercise to the underlying neurological deficit. Obey the symptom rule. Mild to moderate symptoms that settle in minutes is the perfect dose. Remember, severe symptoms past 30 minutes is too much and 0 symptoms is too little. And deliberately engineer adherence right from day 1 using your rationale, video aids, and diaries. That gives us a really solid framework for prescription. Coming up in Explainer 4, we'll wrap up the series by diving into outcome measurement. We're going to look at the MCIDs for the DHI, the ABC scale, and the FGA. Plus, we'll talk about onward referrals and how to close out a 6-week program with a measurable, highly defensible result. Before we wrap, I want to leave you with a quick gut check for your own practice. Think about the home programs you handed out this past week. Are they specifically tailored and truly driving neuroplasticity? Or are they just generic checklists waiting to fail at week 6? I really hope this explainer gave you some actionable tools to ensure your programs are making a real impact. Thank you so much for watching. To explore more on dizziness, vertigo, and imbalance, and to grab some excellent clinician and patient materials, head over to AustralianDizzinessClinics.com. Don't forget to subscribe and leave a rating if you found this valuable. See you in the next explainer.